Today, I have a 16-month-old boy brought with recurrent aspiration leading to recurrent pneumonia. So, what is this case? And this is a documented consolidation involving almost all lobes of the lung. Whenever you have recurrent pneumonia, you need to ask one simple question whether it is recurrent pneumonia involving same site or recurrent pneumonia involving multiple sites. If recurrent pneumonia involving same site, you need to think in terms of a retained foreign body or structural lung malformations like sequestration, CCAM or bronchogenic cyst. But the child also had atrial septal defect, a large atrial septal defect on anti-failure medications. Right now, the child doesn't have any feature suggestive of congestive cardiac failure because multilobar pneumonia can also be due to a large left to right shunt. It could be due to AST, VST or PDA, or it could be due to cystic fibrosis, primary ciliary dyskinesia or primary immunodeficiency. There are so many causes for multilobar pneumonia. But remember, the first question that you need to ask for any child with recurrent pneumonia involving multiple sites, the first question should be whether is there any history of aspiration. If there is a history of aspiration, then you need to ask about the developmental history. When you have a motor developmental delay or a gross developmental delay, then that aspiration could be related to palatopharyngeal incoordination. This case was presumed to be a palatopharyngeal incoordination in the institute that was treating the child previously. So the child was kept on nasogastric feeding for about 10 months. From 9th month to around the 16th month of life on nasogastric feeding. On nasogastric feeding, there was no aspiration at all. When the child came to us, we asked one particular question. Is there any developmental delay? To be very frank, there is no gross motor, fine motor, social language, developmental delays. But the child is on NG tube because the working diagnosis was palatopharyngeal incoordination. Again, in a normal child with a good development, it is unlikely to have palatopharyngeal incoordination as a cause for recurrent aspiration. So we checked the oral cavity for submucosal cleft palate. We did a fiber optic bronchoscopy to look for laryngotracheal cleft. And we did barium swallow to look for a large GERD, gastroesophageal reflux disease, to look for an achalasia cardia, and to look for an H-type fistula. But there was a little bit of constriction in the barium swallow. When we asked that particular segment, the radiologist told it is probably must be due to peristalsis at the time of taking imaging. So what we did, okay, so FOB did not reveal any H-type fistula or any other structural malformations of the lung. So we had a doubt. Then we asked the mother, what was the real issue? When was the real issue started? The mother told that real issue started in the month of, from 7th month of life, when the child was started on solid fits. When the child was started on liquid fits or breast milk, there was no other complaints. So now you have aspiration or dysphagia due to solid fits or aspiration or dysphagia due to liquid fits. When you have a structural malformations like laryngotracheal cleft or H-type fistula or a motility disorder like achalasia cardia, you will get aspiration for liquid fits. But the child was absolutely normal in the first 6 months of life. Okay, so what we did, we removed the NG tube. We told the mother to feed on direct feeding, initially to start with liquid fits, then to convert to solid fits. When the child was on liquid fills like juices, the child was absolutely normal. But when the child was started on solid foods like idli, dosa, the problem of dysphagia for aspiration started again. So right now I have a case of recurrent pneumonia along with a positive history of recurrent aspiration. And right now I have dysphagia or aspiration for solid fits rather than liquid fits. So dysphagia for solid fit means probably there should be a structural lesion. Already we had a doubtful barium swallow. So we subjected the patient for endoscopy. We subjected the patient for endoscopy. Why? Because aspiration started from 6th month of life. You know, by about 6th month of life, we start giving solid foods. And dysphagia right now, solid foods was documented. There was no developmental delay at all. So there is no role or no talk with regard to palatopharyngeal incoordination. So endoscopy was done. Endoscopy revealed. So before that, aspiration history was there. Onset of pneumonia after weaning started, dysphagia mainly for solid foods. So we are suspecting rock solid evidence for a structural lesion involving esophagus. The child was subjected for endoscopy and endoscopy revealed this one. What is this? Congenital esophageal stenosis. So this is a case of congenital esophageal stenosis leading to recurrent dysphagia for aspiration after weaning. In the initial 6 months of life, when the child is on breastfeeding, there was no problem at all. Through this small hole, breastfeeding could able to pass into the esophagus behind the segment of constriction. But once you start solid fits, it is unlikely for the solid fit to go into the narrow part of the lumen. So this is a case of recurrent aspiration leading to recurrent pneumonia. The clue was dysphagia for aspiration after weaning. The clue was dysphagia for aspiration after taking solid foods. So dysphagia for solid foods means you need to suspect structural pathology. You need to subject the patient for endoscopy to find out the diagnosis. Thank you.